Special episode today, guys. Thanks for listening to the True Sports Physical Therapy podcast. Today, my guests are Dr. Tim Stone and Dr. Rayce Hauser. They just put together an unbelievable in-person ACL course. That's going to be August 30th and 31st in the beautiful state of Maryland here in Baltimore in one of our awesome clinics in Bear Hills. You guys can sign up for this course. We got discounts running as we speak, and spots are limited. So make sure you grab them. It is going to be an in-depth, in-person course as to how to take your athlete all the way from surgery, all the way back to the field. Tim highlights in this upcoming conversation how he structured the course. Rayce talks about how you progress through the different phases of ACL rehab. But what's most important about this course is that these guys are absolute experts, have seen more ACLs than anyone else in the country, and 70% of the coursework is actually lab work. So they're running you through the drills, the exercises, so you know what it feels like, how to load your athlete, how to get all your range of motion back for your athlete. And then what's most important, I think, in this coursework is how to teach that athlete how to cut, how to decelerate, accelerate. You're going to get it all. It's August 30th, 31st. Make sure you sign up. You can find it on our homepage, truesportspt.com. You can find it on Instagram, truesportspt. We would love to have you. So without further ado, here are the ACL experts, Dr. Tim Stone and Dr. Rayce Hauser. Welcome back to the True Sports Physical Therapy podcast. I got two of my favorite guests. Now, both these guys have been on before, Dr. Tim Stone, Dr. Rayce Hauser, always talking ACL. I think, Tim, you and I did a return to sport after ACL. Rayce, you've been on here God knows how many times, always a popular guest. I'm excited to talk to you about your new in-person upcoming ACL course. So just walk me through what inspired you guys to create this in-person course and what gaps in current ACL education are you hoping to address? Rayce.
All right. So I think we look at across the board at times, how bad ACL or how bad of care individuals can still get post-op, after ACL surgery. And when they come to us, let's say they went to another clinic, another PD provider, and they went there for a couple months, they come to us, they're still lacking 10 degrees of extension from neutral, can't really activate their quad, still have 3+ for swelling. And especially when there's still a lot of great information out there that people can get for free, I think at times just the amount of information that's out there can be kind of overload, and just, what's important, what's not. And so I think when we put this course together, it's okay, what are the meat and potatoes of ACL rehab? How can we synthesize all this information to give you sort of what you need to maximize your outcomes with the patient? So I think that was sort of the big thing we're looking to address, is just make sure that, one, with all that information out there, here's what you need to know to get your patients better. And two, when you get back to the clinic Monday morning, you can start using all these different principles, tools, to give better care to your patients.
Okay, now we already have an unbelievable virtual course. Tim and I put that together, and that's been out on the market for 2 years. So, Tim, what made you create an in-person course?
Yeah, it's a really good question. So, I think at one of our True Sports end-of-year parties, actually, Rayce and I got chatting a little bit about, what are the benefits, of taking things virtually versus in person. And I think for me personally, I always like to take courses in person. If you have a ton of things going on outside the clinic, as many clinicians do, families, other roles and responsibilities, within your clinic, it's very hard to make that commitment to your education, at, 5, 6, 7, 8, 9, 10 o'clock at night. And so I always found when I took virtual things that I would sort of purchase it, be really excited by it, maybe get through the first lecture or two, but then life kind of happens and it gets in the way, right? Like you have kids to help, homework, or, you've got other things to go and attend after, and it sort of becomes the last thing on your list in terms of priorities. So we started chatting and really felt like if we could, repackage this online version into an in-person version, you can make that commitment and hold yourself accountable by, just selecting one weekend of the year to physically be there in person, and learn in a really intense fashion. And I would say also on top of that, you really get, I think, a a better long-term memory when you live and experience this type of learning in comparison to reading or listening. I certainly feel that too. During most of my week, I try to consume information from podcasts or articles or books. I think a lot of that can go in one ear and out the other. But when you do something, you live it and experience, you really internalize it, and I think it makes it much more easily applicable when you're back in the clinic, like Rayce said, on a Monday morning working with a patient with an ACL. You can sort of say, "Oh, I remember when this came up. Dr. Rayce talked about how you could work through this," and that's really vividly, clear in my memory.
Yeah, I think those are great points. Like that's a huge promotion for why to take the in-person course. Another thing is you're surrounded by professionals that are doing this day in and day out, whether it be from the instructor side, Tim and Rayce, or whether your other classmates, and you just don't have that when you take a virtual course. I'm picturing, Tim, like you sneaking down to your basement, taking this course in your basement virtually, how different that is from the energy you're going to feel by being with like-minded professionals, and also the networking ability, the ability to connect with other therapists, know where they work, understand where they work, how different kind of situations lend themselves to patient outcomes. I think there's a tremendous amount that you can kind of get there. So in your view, walk me through what makes this in-person course different than any other in-person course that may be out there, Rayce.
I'd say a big thing, and I know we've all talked about this a ton, is skin in the game, in the sense of, I know we all treat a ton of ACLs, but in the sense of we're actually going through the same, similar training that they're going through, especially when they get to pre-running, when they get to cutting, when they get to jumping, strength training, all of that. Like, we're experiencing that ourselves, just trying to enhance our lifespan, enhance our own performance. And so I think because we have skin in the game in that sense, when a patient may think that they're at a RPE 10 for, a squat or leg extension, and with my visible eye, I can definitely see they still have 5, 10, 15 reps left in the tank. I can see there's a mismatch between what they feel like they can do from a failure standpoint compared to my coaching eye. And so I think having that experience of understanding what it's like to achieve true muscular failure, or what it means to achieve true technical failure from a skill standpoint, I think then we can start to better apply dosage parameters from an exercise standpoint, not only from resistance training, but as we start to progress into change direction and more sport specific tasks. I just think we're better able to give them what they need at sufficient intensity and volumes.
And when you say we're better at that, you mean this course compared to other in-person ACL courses?
Mm-hmm. Yeah, I mean, I know I'm a big advocate of strength training, performance training, all that myself. I know Tim's also there. He's still playing lacrosse. And so I think because we are immersed ourselves in the actual training itself, like, we better understand, hey, this is what it takes to get certain adaptations. Here's what intensities we need to drive to get strength faster, get strength better, improve our reactiveness. So I think because of that, that's what makes our course different, is because we're actually doing the thing.
Okay, still doing the thing. So you're making the case that the instructors of this course are a different caliber than you'll get elsewhere. What about from the outline of the course, Tim? What makes this course different than other ACL in-person or virtual that's out there?
Yeah, so I've taken, a handful of virtual and in-person courses, on, many different joints and techniques, manual therapy, performance and things like that. And I think what we really set out to do with this is, unequally weigh this towards the lab portions of the weekend. So we have roughly like 70%, 70+% of the time that we're spending teaching and educating in the gym, in the weight room. I think I wrote down, I think we're going to set out to have every single person who returns from Saturday to Sunday come back with, DOMs, right? Like, we want them to have soreness in the quad. We want them to really feel and experience what it's like to work, like Ray said, at like a 7, 8, 9, or 10 RPE whilst doing these exercises. We talk, at nauseum with this with our PTs, when they come to work with here, when they come to work with us, and when they're developing as new clinicians, we always say, like, it's really difficult to give an athlete something that you yourself don't know how to perform, even at a minimal level. And so I think that really is, a hardcore theme of this course specifically. We want you to experience what it feels like to go through the advanced loading portion of this protocol, or how our brains work in terms of breaking down and progressing the different versions of plyometrics or cutting and things like that. And so I think, like I said, we really want clinicians to be able to feel what it's like to run the True Sports ACL protocol with their patients, but to do it first with themselves so that they're better equipped to, send that message and treat patients at a higher level.
Yeah, that's such a differentiator. I'm glad you've highlighted that, because I've taken, I can't even count how many in-person ACL courses that I've taken, and it is so much lecture. It is so theoretical, and this is what I love about this course, is that it's the opposite of that. It is so clinical. It is in the trenches. You're actually going to feel what it's like to break down, to properly decelerate, to change directions, and then, of course, Rayce is highlighting to be under the proper amount of load, how to progress and how to scale that. That's invaluable. I love that. So both of you guys highlighted the quad recruitment aspect of this. Let's get a little clinical. Rayce, you and I did an entire podcast on how to wake up one's quad. So let's start with Tim. Tim, what's your first approach that you plan to teach in this upcoming in-person ACL course as to how to wake up the quadriceps?
Yeah, so we break down the different sections or phases of the rehab really clearly, and that first little phase, we call this protection or regaining motion phase, but we really listed out specifically in day one, week 1 to 2, 2 to 3, and then in this protection phase through that first 4 weeks. So I think we're really detail oriented in the way that we go through this. I don't think that comes through a lot when you're reading a protocol, that you might get from a large hospital-based system or something like that. But specifically, I think, my big hitters in terms of waking up the quad initially don't even relate to working on, squeezing or initiating the quad activation. They really relate to calming down the knee early. All right. So that's decreasing any swelling or inflammation, right? Decreasing pain, and then also regaining that passive range of motion. I think only we can talk about great techniques to get the quad functioning well once we've done a really good job of that. And typically, you don't need to be a rocket scientist, or have 10 million tricks up your sleeve to get the quad to fire up and go if you do a really good job of those things. So, I'll pass to Rayce on specifically, what he does to wake the quad up once you've done those things. But I think it's imperative that people understand that it's so important to hammer out these other little things, first before you sort of go after that.
Okay, before Rayce jumps in on that, tell me how you do that, Tim. How do you get this knee calm and ready for that next step of quad activation?
Yeah, so I think a really big quote that kind of sticks out in my mind is early and often. I think we use that a lot in sports, but I think it applies here a lot too. So that's getting patients in, immediately after surgery, within 24 to 48 hours, and beginning to start to work on some of those things. So a huge piece of this is, educating on things the patient can do to decrease their pain throughout the day, right? Like elevating the leg, propping it up so it encourages that passive extension through low load, long duration stretching. And then in the clinic, specifically what we'll do is I'll typically elevate that knee and a whole leg into, to hip flexion, or just tilting the table up. And then we're just doing some retrograde massage, patella mobs, things like that to try to sort of just clear some of that swelling. And then moving into, passive range of motion knee flexion, which we also always do to begin with, sitting at the edge of the bed. Just so that you can get, some distraction on the knee joint or that tibia as you lower the leg into flexion. It just seems to be a much less painful way to kind of do that and regain that motion. I didn't used to do that so much. I used to do the classic like heel slide or push, and I'm getting 20 to 30 degrees on the first day, and ever since I switched to doing that edge of bed flexion 4 or 5 years ago, I started to really see that I was able to kind of reach that 90-degree flexion goal within that first day or two. Obviously, protocol permitting, if there's no meniscus stuff, and we're allowed to go there, obviously.
Yeah, somewhere Lenny Macrina is smiling. Okay. Also, you make a good point where you're using these like tried and true principles, but intelligently, right? Like how often are therapists out there just massaging because they were told that that's what they're supposed to do, but really using it to target a deficiency like a swollen knee. So elevating the knee, doing some soft tissue work to clear some of that fluid. Another thing I want to highlight is not just patellar mobs, although patellar mobs are imperative. Patellar tendon mobilization is also super important, making sure you're spending time to get that knee as normal as possible. Because Tim, to your point, you're never going to wake that quad up if the knee is not doing what it's supposed to be doing. Okay, so after you spend some time doing that, I love your edge of the bed technique. Then it's time to wake up the quad. Enter Rayce Hauser. What's your first intervention to allow that?
So I've actually kind of shifted my approach a little bit. I definitely
shifted it since our last pod. Do we have to re-record that?
More so in the sense of like where I'm probably starting intervention wise. Like I'm still blasting a ton of reps in terms of we're trying to shoot for at bare minimum 500 reps a day. I'm still trying to have them shoot for 1,000 reps a day. Just it's such a low stress exercise that we can just generate a ton of volume. But more in the sense, when they come to me, day one eval, I'll still check to see what quad activation is like when that knee's fully extended. But I've actually shifted similar to Tim. Like I'll get them edge of bed, get that knee into flexion. And then from there, just because we're in a better link tension relationship, I'll either have them try to do leg extension isos, kind of whatever position from a flexion standpoint is tolerable, whether it's 45, whether it's 60, if it's 90. And we're just doing some sub-max isos into my hand. That better link tension relationship, just one, better maximizes the quad. There's also been studies that have looked at what sort of neural drive or cortical drive we get based off knee position, and also an extension, it's the worst. So we have a double whammy in terms of link tension relationship is garbage in full extension. Neural drive is the worst. Also, if we want to couple on top of that, intra-articular pressure is also pretty high in full extension, which is going to put increased pressure on the capsule, further facilitates the AMI. So we have this triple whammy effect. So if we can get them in a little bit of flexion, decrease that pressure within the capsule there, improve link tension relationship, we're just setting them up for a better position to get quad recruitment. And typically, if you can start there, have them get some leg extension isos in some of those slightly flex positions, get them back into supine or on the table. Typically, you'll see a better quad contraction in that fully extended position from there. Not to say that we're not going to still work on quad activation in that extended position. That's still going to be very important, especially as it comes to gait and working on gait mechanics and controlling that terminal knee extension. But in terms of activating the quad, definitely have shifted much more towards let's be in a slightly bent position. Let's try to work in better link tension relationships and more favorable joint environments in terms of joint intra-articular pressure. And we're still
great things to think about. Let me ask you a quick question in there. Where do you put, if you're doing it hand resisted, where are you putting your hand on the tibia? Same question if you're doing it on a knee extension machine.
Yeah, typically it'll be distal tibia with hand placement there. And I think once, after a couple days, they can tolerate that fine. I think this is where Tyndek comes in super helpful in terms of I can take a look at torque steadiness. As they're kicking, do we have more of the sawtooth pattern from a torque steadiness standpoint? As we both in session and between sessions, I can see improvements in terms of torque steadiness. So that smoothness of that line will typically improve. Also, I get an idea of what their output is, how hard can they kick with minimal pain. If we ramp things up to maybe a 2 out of 10 from a pain standpoint, how hard can they kick? And we can just keep on progressing that forever. Also, I can generate a ton of reps, a ton of volume with that, just because with the isometric contraction, we're not going to generate a ton of muscle soreness or DOMs.
Okay, give me rules of pain, and then also talk about reps and holds.
Mhm. So I would say, especially in that sort of protective phase, regain motion phase, I'm probably trying to keep things pain-free, maybe at the very most 2 out of 10 pain. Like Tim said, goal here is to keep that knee quiet, keep it happy. So I don't want to be too aggressive where we further facilitate swelling and more inflammation. Um, as we kind of get a little bit further out, maybe we start to get to that 4 to 8 week mark. I'm usually okay pushing into a little bit more discomfort, but it really doesn't change a ton. Maybe we're 3 out of 10, maybe at most 4 out of 10, but typically I'm going to do a sweep test every time they come back in and just make sure that their knee swelling isn't getting worse from, either our interventions or what they're doing outside of PT. From a dosage standpoint, it kind of depends. I feel like they probably tolerate 10 to 15-second holds sub-max for those first couple weeks. And then once that knee starts to calm down a little bit, pain's more under control, I feel like we have a better ability to play around with our set rep scheme or our durations for our hold times, whether we're doing 5 by 45 seconds, whether we're doing 5 by 90 seconds, 4 by 90 seconds. So I feel like once that knee is calmed down, that graft site is calmed down, I feel like then we can start to be a little more creative with our variations or our parameters. But initially, I would say that sort of 10 to 15-second mark is probably a pretty sweet spot for hold duration.
Just hearing those rep schemes and that dosing makes me want to sign up for this course, because I don't think you're going to find that crap in textbooks. You might see it in our virtual course, but hearing that from you, experiencing what that's like, certainly reason to kind of sign up for this. So I love that. And the use of the Tindeck that early is awesome. Anything else you're using super early? Like, when do you go to BFR in this? Do you use it in this protective phase?
Oh yeah. Like, I'm probably waiting to that end of that first week and the second week, super low occlusion. I don't want to get too aggressive with the occlusion pressure, just in the event that somehow the pressure gets too high and we start getting some fluid to kind of seep out of their incisions. But typically trying to put that on ASAP, just more trying to create sort of this anti-catabolic sort of environment where if we're not getting to a point where we can load sufficiently to get at least a hypertrophic environment, at least we can try to mitigate the catabolic effects from some of that disuse and less loading on that limb.
Okay. That makes a lot of sense in terms of setting them up. First of all, they're getting used to the idea of having a tourniquet on their leg, so it's going to set them up for future use. So I love that. And then you talked about dosages for activation. Talk to me, Tim, about dosing range of motion at home.
Yeah. So for the passive piece, so for passive hyperextension, okay, we're just doing that heel prop is what we call that here, and we're doing that 5 times a day for a minimum of 5 times a day. For at least 15 minutes at a time. Okay, and then we're putting bag of ice to add a little bit of weight and the compression and ice to help encourage that hyperextension, and that's going for 15 minutes. So we're accumulating at least 60 minutes of low, long duration, with the goal of being 90 minutes and above for extension or regaining that hyperextension. And then for flexion, I sort of teeter between this based on patient tolerance. I really think, if I'm seeing them for a high frequency, this is something that I think for patients is much more fear-provoking. So this is one of the reasons why I like to see people, 4 to 5 times their first week, so I can handle that for them, because I don't think there are really great options for the passive range of motion for a patient themselves that replicates that edge of bed. So like some people might hook the other leg and drop it down. I don't feel that is really easy to do truly passively, or you're asking a partner or a parent to do that for them as well. And oftentimes they're like, trust issues over, dropping the leg or moving, too fast or something like that and provoking pain. So I want that to be done a minimum of 3 times a day for 5 to 10 minutes. But I will dose it much higher when they're in the clinic, if they're handling the hyperextension piece on their own well at home. So I might spend, 20 to 25 minutes in that first week with them in a 45-minute session working on that flexion.
Okay, so you raise a good question. One is, how do you do that flexion in office? Public service announcement. Tim is just an absolute hero with the way he is overcoming this man cold. I mean, you would never know. He's here coughing up a goddamn lung. He's got 5 kids in the background. We don't even hear them. They're so quiet back there, just holding down the fort. Me and Rayce are really impressed with your skills. Not one spouse would be impressed with your performance today, but Rayce and I are very impressed. So thanks for weathering the storm.
Okay, so for in the clinic, I'm swinging them around so that their legs are hanging over the edge of the bed, and I'm supporting their heel so that it remains in extension. And then you can put a half foam roller, or you can roll up a towel and put that under the knee. Or I also like to just throw my forearm under the leg and hold the heel, and then we're just letting gravity do its thing and just bringing that heel down towards that 90-degree mark. The reason why that I put a towel roll, foam roller, or my arm under their leg is just the weight of their leg. If they're sitting on a plinth, will kind of drop that knee below the level of the hip. So when when gravity's effect on the shin kind of runs out, as they're perpendicular to the floor, if you don't prop their knee up a little bit, you're going to run out at like 70 to 80 degrees. But if you throw that little prop underneath and you elevate the knee a bit more, then you're truly going to get to that 90 degrees before gravity's sort of like no longer working. So it just gives you a little bit more leeway to get to that point before you have to like push on their shin, and that's not really a comfortable thing to do for most patients.
Would you ever get them prone?
Yeah, I do. Typically not in the first session, and less likely, in the first week. I really focus on that, especially it's kind of like a workaround cheat code if they have a 90-degree limitation on their protocol. So if they have a meniscus injury as well that's been repaired, the protocol is going to say 90 degrees, right? But if you get them to 90 edge of bed, right, we're not really at the hardest position to achieve 90 degrees, right? Because the hips flex, so that quad doesn't, have as much tension on it as it would be if you're in hip flexion. So if you lay them prone, and then you can also put them in a little hip extension, same thing with that foam roller. You just prop that knee up, and then you can start going through flexion there. If you can achieve 90 degrees of flexion with an elevated knee in prone, that's much more difficult than obviously than when you're sitting. And so, the range of motion beyond that, when you do get released to go full range of motion, comes back a lot easier. And you're addressing, not just, joint tightness, right, or stiffness. You're also addressing, that involvement of the quadricep / hip flex or in knee flexion.
Yeah, I think those are all important points to kind of think about. Obviously, what the quad is doing, how much slack it's on, whether it's tension across that hip, moving them into a hip extension. You bring up another great point, which is this is really where rubber meets the road. It's totally different talking about how you're going to treat this patient, real world versus protocol. So you mentioned 4 to 5 days a week that first week. Kind of walk me through your sales pitch to that patient, because the patient or the mom of the patient or whatever is going to say, we only have so many insurance visits, so I can only come in twice a week. How do you handle that?
Yeah, I think that is something that we run into, a ton. I think with experience in seeing the difference between patients that do a high volume of therapy early and those that do not, really allows you to impart that on your patients with confidence. That's difficult when you're a newbie, but if you come to something like this and you can learn from people with experience, what we always say about new clinicians is, don't say, I think this is the way to do it. You can say, like, we as a group, like we as a company see this kind of thing all the time. We as a company expect our patients to come in 4 to 5 times a week early on, because we as a group or we as a company see way better results, when people do that a lot. So I think that's the first way to get through that sort of barrier. I think the second thing is, and I always say this, I've never had a patient that successfully returned to sport say, oh man, I wish I saved a couple $100 earlier on in that rehab. I feel like I could have done this well, but gotten better value out of my care from a monetary perspective. But, there are a ton of patients, I think, that end up having range of motion issues, that end up having to go under the knife again, and getting scar tissue removal or MUAs that would, if they had the opportunity, have gone back and done that, and once you start going through that process, you're back at square one, right? Like 9 to 12 months ticker starts again from that second surgery, because you haven't really been successful at gaining any strength or range of motion beforehand. And so you're just prolonging the injury. I think also too, success drastically goes down after the inclusion of a lysis or an MUA. And then, thirdly, time, even from that day one point, still goes up higher than your typical like 9 to 12 months. So I just think there's such an argument for doing a ton of therapy early on, and a very, very weak argument for spreading it out over the lifetime. I think it's the most critical portion of ACL rehab that you must get right, because there's no getting to part B, C, D, E, and F if you don't get part A right first. And we see it all the time when people come in after like 6 months of rehab and they still don't have, a straight knee, from elsewhere. And it's like, you're doing this whole thing again, which ends up costing more as well.
Yeah, I like the way you handled that scenario, because you handle it head first, where you're going to talk about the dollars and cents. And I think as a profession, we run from that too often, where if you can say this is actually a better economical decision than it is a clinical decision, you're able to have that conversation from a standpoint of confidence. I think that goes a really long way. You bring up getting to the next phase. So that brings up my next question, Rayce. How do you determine when your athlete is ready to progress to the next phase, let's say from this progressive or protection phase?
Yeah, so I think big thing when we start to look at what probably is the next sort of big milestone is probably going to be that sort of return to walking progression. And, big thing we're looking at full extension. And when we say full extension, not just leg can get to 0 or neutral. Like we need to get full hyperextension at least within 2 degrees of that contralateral side. Swelling then less than or equal to a 2+ with that sweep test. Heel pop should be easy, non-negotiable. It should just be bang right away. And then depending on who you talk to, 10 to 20 straight leg raises without a quad lag. I'm starting to kind of change the straight leg raise a little bit, in a sense of I almost want to start playing around with like an RFD, where maybe we set a metronome and now we're talking about trying to recruit the quad in a quicker manner, just because I'm thinking in terms of ground contact times and how fast that occurs with walking. And when we start looking at ACL research in terms of looking at post-traumatic osteoarthritis, it seems that RFD, or rate of force development, or rate of torque development specifically of the quad, seems to be maybe a bigger indicator of that compared to just strength alone. And so maybe we could continue to progress our straight leg raise criteria to include a metronome version of that, just to target a little bit of a faster quad contraction. That's just more kind of me spitballing there on that metronome. So that's the big thing there. And then I know some people have thrown out different sort of metrics that they want to see from a torque to body weight standpoint for quad. I know some people have mentioned a 1.0 at least Newton meters per kilogram for peak torque to body weight before they start getting them on the floor, on the ground, doing squats, doing various closed chain exercises. Just because if they can't achieve that 1.0, they're not going to recruit quad in a closed chain position, and likely going to do everything entirely. Yeah, essentially everything around the quad. Recruiting hamstring, recruiting glute, recruiting calf to get that pseudo knee extension.
Okay, so. And if you don't have a Tyndek, like if you can't get that torque number, how do you progress them?
So I think then it comes down to, can we try to get some form of constraint to try to bias that quad? So can I set them up in a situation where I'm really trying to decrease utilization of the hip extensors and the hamstrings, trying to get that force vector through the ankle in a situation where they really cannot recruit calf. And so largely becomes a quad-based exercise.
Wouldn't be a race podcast without the word constraint. So tell me what you mean by that, and then tell me how you use them.
So essentially, it's just a fancy word for I'm going to set up an environment to be conducive to whatever sort of quality I'm trying to target or whatever sort of tissue I'm trying to target. Whether it's, since it's ACL, the big thing is going to be quad, and they're going to do everything to work around that quad. So I'm going to set up, foam rollers, external objects to try to drive as much stress to the quad as they can. So that's kind of the big.
How do you do that? Give me some like low hanging fruit there, because inquiring minds want to know. Give us the answers, Rayce Hauser.
So every clinic has this, a wall. That is your easiest option to use in the clinic. No excuses for not loading the quad or not having them do some sort of squat up against the wall, going up and down. When they don't have the wall, it's pretty much an RDL. Other thing that I think is super low hanging fruit, same thing, every clinic has it, is a foam roller. So kind of have two different means to try to increase the moment arm for the knee to drive more stress to the quad. So one is adjusting for shrunk angle, which the wall will do. We can use the foam roller to get into the 10 point here.
Contagious, cross-country contagion.
But foam roller to try to get that knee over toe to try to drive more stress to the quad that way. So I would say those are probably the two easiest things that people can do in the clinic. In terms of trying to get our pseudo test for our quad strength, if we don't have a Tindec, I don't know how many people are familiar with the Eric Mara squat, where heel is up on the wall, their back is also up against the wall there. And if they slide down and get to 60 degrees of knee flexion, that ends up being pretty close to a 3.0. So then, if we reduce that, let's say they can get to 10, 15 degrees, that's probably pretty close to a 1.0 from a bodyweight standpoint. So if they can get to a little bit of knee flexion in that sort of single leg Eric Mara squat, that's probably a point where we can start to look to get into a little more closed chain exercises.
Dude, that's a good freaking answer. I love that. And a great way to somewhat gauge where your athlete is and how you progress them. Okay, and then that next phase is our strength phase. What's your first intervention once they're able to be closed chain, quad recruited, strength phase?
So, I'd say two things I typically look at is, one, we're definitely going to continue to work on TKEs or work on terminal knee extension and sort of different loaded positions and loading parameters more so, as
Rayce,
we continue
hate TKEs. I feel like they're so cheatable. Make the case for TKEs.
So I will typically, the cue I really use that I feel like I've had better success with is driving the heel into the ground. So I'm trying to more force them downward to get extension, versus if I feel like if they think about more just pushing the knee back, I think that's when we start seeing more of the glute hamstring. So I would say I've had better success with driving foot down as the cue, like squishing the bug is sort of a cue I'll give to someone, versus, hey, just push your knee back and straighten it out. So I don't, it's like something I do 2x20, 2x30, 2x50, like it's quick and dirty. I think it's not our best bang for our buck. I'll still include it just to make sure that we're still working some stuff sort of in that terminal knee extension position. But then we're getting sort of more into the meat and potatoes, where we're getting more of our longer moment arms for our quad in our flex positions. I'm not the biggest fan of doing a ton of double leg exercises. I will use it initially, like with our squat, to get them acclimated to weight bearing. And then we can sort of use a very easy progression from a double leg squat to a double leg off leg squat, where we have like a 45-pound plate underneath our contralateral side. That's going to naturally just shift more weight to their cervical side. They tolerate that well. We move into our split squat. Of course, I'm going to be using constraints here because I know they're going to try to use a hip dominant strategy to work around it. So maybe it's that split squat up against the squat rack or a wall, going up and down there. They tolerate that well. I'm probably living there between that split squat and our true single leg squat or single leg step down up against the wall there. And we're going to keep, hammering a ton of single leg or bilateral asymmetrical loading with the split squats until we probably get to around that 80% LSI mark. And that's where maybe I start to normalize volume allocation a little bit between bilateral and more of the unilateral base loading. But I'm just thinking I need to try to drive as much stress as I can or to the quad itself. And if I allow them to use that contralateral leg, it's just another means for them to work around it. So if we can at least eliminate one of those avenues for compensation, we can probably be a little bit more confident we're driving a little bit more stress to that quad.
Love that. Okay, so once they hammer that out, when do you move on to the next phase, and what is the next phase, and what are the must-haves before you get there? Tim.
So, okay.
God, come on, Rayce. Yes. There's someone else here.
This is like Rayce's baby, like this loading stuff. So he probably could do a much better job of answering this question. After we get through that initial loading phase, we just break it down into like a more advanced loading phase, which follows the exact same principles of the initial loading phase, except for we're just adding more external resistance, right? Or we're finding other ways to increase the force, through the knee or whatever the target tissue is for that day. But it's very similar. What we tried to do in this course is there's some exercises that like require, so much force through the joint just from like body weight to begin with, that we sort of omit them from that initial loading phase, right? And so then we bring those into the advanced loading phase. Like you could, imagine like Rayce's heavy constraint, like with the wall, and having somebody try to do, a pistol squat like below 90 degrees, right? Like, although there's no external resistance, like that's so difficult so early on, and there's such a high level of force that like we just don't have that in the initial loading phase because it's too hard to make it like offloaded as much. So those things come back into the advanced loading phase. And then, we get more creative and more playful with, barbells and, and bands and, like upper extremity supported things so that we can really drive some of that like neural load, speeds, tempos, all those kinds of things in this like advanced loading phase where you can really start to, play with not just the ability to, control body weight forces through the knee, but now you can, start to, begin to get in excess of, body weight, and with the addition of different like time and speed, which increases like, the force across the joint. So some of those things just we're not able to regress so much in the early phase, like or the initial loading phase, that they come into the later phase. So a really good example of this is, don't want to just talk in like principles, but really specifics. Like something that sticks out into my mind here is we start like using these like Hatfield progressions. So like for a rear foot elevated split squat, for example, if you have a safety bar and then some pins that you can attach to the rack, you can use the patient's arms or upper extremities to hold those pins so that you can load that rear foot elevated split squat up so heavy, but you're still not making this a balance task, right? And that's one of the issues when, Rayce is talking about we don't want to bring in bilateral type loading until they get to a certain point so much. We want a heavy emphasis on single leg, but like there's only so far you can go with a loaded pistol squat, or not that a rear foot elevated split squat is like purely single leg, but it's at least emphasizing to that front leg. You can only go so far until you lose center of mass and the exercise is cooked, right? So bringing some of those upper extremity like helpers in so that we can put 200, 300 pounds on a bar and really crush it, but still remain single leg, so that we don't have to go to a 400 pound, 300 pound squat where they're just cheating and using, their unaffected side. So that's kind of what you see more of in this advanced loading phase. And that typically starts around like, similar time point to when we, just prior to when we start doing like our return to run phase. So we're talking like 75% QI, HI, type numbers. And then same things in terms of the KPIs previous to that, right? Minimal swelling, 2+ Rayce talked about. We're probably hoping for less than that at this point. Pain-free with like a full depth squat.
Okay, so that's awesome. I think where a lot of therapists struggle is this moving from your loading phase to your next phase. So walk me through what the next phase is and KPIs to make sure that they're okay to get there.
Yeah, so we have a bit of an overlap here. So we're in the advanced loading phase. Like at some point within that, we're going to hit the return to run phase. And then, from the advanced loading phase and return to run, if we kind of like clump those because there's some overlap, you'll then eventually progress into this return to like sport phase, which is what we call our like prep to return to practice. So it's not competitive quite yet, but like plyos and cutting and things like that. So it is a difficult transition. What I think is an easy way to do that is as the loads increase, like you'll start to see the strength get better. Then once you want to, then you have your tests, those come out great on your KPIs for clear for return to run. Then you dump those loads off, right? Reduce everything, and then you work at like much more pace. And then you start to begin, the landing, jumping portions, like of the prep to return to run, right? So there's like an increase in loads, but the tempo is pretty slow, right? Because the load's quite high. Then when you want to transition, we sort of dump those loads one time a week, or maybe it's 2 times a week, and start to move much faster, but with much less external load. And then that trickles into your, preparation for plyos or like those pre-running drills where there's a lot more speed going over the knee and much more impact.
What's your first foray into upping your tempo?
So I think you could. The difficult thing with this, I think the largest thing I would say in terms of a jump would start to be these like overground drills that I would do. So I call them like walking, like catches or sticks, right? So patients walking, and then when they move onto the unaffected side, they're getting prepared for that like initial contact phase. They basically do what you would see in like a snap down, but they're not stationary, so they're moving, their weight's moving forward. So there's some like linear deceleration involved. So they basically like when they go into that step, they just drop and catch, and then they stand up, they walk a couple more steps, drop and catch on the other side, and they kind of cycle through that. Those are really like, and then you can do it without the steps in between. Just go from one catch, switching side to side, and then you might start with some like smaller, like jumping some like extensive base pliers or like short pliers, short depth pliers on 2 legs versus split legs or 1 leg. But those like all I would say were like bucket into this like exploratory phase of like, do I think this person's going to be appropriate to run? And before we had access to Tindeck and force plates and all those kinds of things, we really had to guess what the strength output was for someone. We didn't know they would be at 75% QI. And so I would use like that grouping of exercises that I just talked about then as like I think they're ready to start this return to run phase. Let's do a session, see how far they make it through that session. And if it goes well, then we'll progress into the return to run. And I think that's still really valuable to be able to like do that and see that as a clinician. While it's amazing to have access to all of those things, not everybody does. A lot of those things are, a lot cheaper and more accessible right now. But I think it's important as a clinician to be able to see, if someone can bridge the gap from heavy, slow resistance to like, faster, lighter resistance type exercises, that then you're pretty confident that they're going to be able to also run well, right? You just backtrack 10 or 20% of the loads that you think are going to happen during running. If it goes well, you progress and they're off and running. And also I think too, like last piece I'll add here is, we're not going from heavy, slow, like resistance straight to running. There's like a large gap there, right? But if you go in the middle and you take that bite-sized chunk of progression and it doesn't pan out awesome, it's cool, like no harm, no foul. Go back into your heavier, slower resistances, build up strength a little bit more, and then go forward into and try again. And there's very low or like there's very minimal risk of when you're doing these walking catches, or catch side to side, that like you're going to set them back like 6 weeks by blowing up their leg. Whereas like if you guess straight away into that running phase, and then they have a terrible day, like that can blow them up. So just a low risk, low way of entry.
And I think maybe like a happy medium, like when you do your catch drills, if that doesn't go so well, then you can come back to drills that they know and love, they've already mastered, and just start adding. I think it's a great use of metronomes, adding in some pace, a movement pattern they've already perfected, so that they can get used to some of that rate of force development, which is necessary. Is there any room there for stationary snap downs? Like, would that come before your cycling snap downs?
Yeah, I think you can. I think, these are kind of like hot, people like ragging on these on like, on social, and how doing these things here don't equate to doing those things in the field, but that's obviously like not the point at this time. I think you definitely can. I like the walking catches because it just mimics like the gait cycle a little bit more, and I don't think it's that much more difficult than doing a snap down. I like that you're alternating side to side when you get that like cyclical nature. So there's something to me in terms of that like flow. Rayce could probably give a better like neurological term from this, from like being able to move from like, the unaffected limb to the affected limb, and how that improves by, doing the unaffected limb. I like that cycling. I also think when you're doing a snap down, all of that load is like purely vertical in nature, right? But when we're running, there is some sagittal plane movement and forward progression. So I think you get a better sense or a better idea of what's happening in running by just adding a little bit of that like motion into the drill. But I certainly don't think like you're doing it wrong if you do a snap down or even just a small drop off the box. I like the walking ones, and you get more reps done quickly, right? You don't have to reset like every single time, right? You can get in 20 yards, 10 to 15 snap downs walking, rather than having to like snap down, reset, snap down, like reset. So I prefer that, but again, I've done both.
Yeah, I think that makes a lot of sense. Rayce, anything you wanted to add to that?
I know one thing I've been a big fan on lately is, and I know that when they get back to running for the first time, they're not running at the speed. So when we look at vertical ground reaction forces, when they're running a 9-minute mile at that pace, there's about 3 times one's body weight going through one leg. And I need to play around more with like, hey, if an individual weighs this much, how high do we have to jump and land from to get 3 times one's body weight through a single leg for that double leg kind of movement and jump? For myself, when I was testing it out, a max vertical jump and a land on that land from about 17, 18 inches produced about 3 times my body weight through one leg. And so a lot of times, if they can tolerate a max effort counter movement jump, and then we monitor things, they don't have any reactive swelling, knee feels pretty fine in terms of pain. At that point, I'm pretty confident as well that they're going to be able to handle that return to run, or at least getting back into running at that point.
Okay. And then you kind of piqued my interest around force plate stuff. So if you have access to force plates, when are you introducing those into your rehab protocol?
It could be super early. I mean, it could be as soon as they start getting weight bearing. Hey, what does the weight distribution look like from right to left? Are they shifting away from that cervical side? It's also a super easy form of external feedback where, I can see the difference in like, as the force plates are reading, like they have a line for their left leg, a line for their right leg, and they'll just kind of both go across at the same time. And they can very easily shift within that exercise to put more weight through that side, and then they get the visual feedback of, hey, these lines get closer together. So it's in that sense of, hey, as you're, just in quiet standing, I want you to keep these lines on top of one another. And then we can keep on progressing that. So let's say we get to, we'll just use 4 weeks as an example, and we're doing double leg squats, and they can get the visualization of, hey, I see when I go down and I go up, I have this big of a gap between my cervical side and non-cervical side. And my cue to them is, hey, like your goal is to squat and get equal, or essentially have those lines mimic each other. And then from there, it's them trying to figure out, how to go about squatting to essentially get at least the same force through both limbs there. Another easy option too I'll use with the force plates is patients don't have access to this at home. So how can I better dose exercises or create exercises at home for them where I feel more confident that they're actually getting more stress or more load to that quad? And super easy thing, I mentioned this a couple times throughout the podcast today, is just putting a plate on the unaffected side. And then, like, let's say their left side is the unaffected side, left foot's there, right foot on the floor. That naturally shifts somewhere between that 15 and 20% of load to the opposite side. And a very easy way to at least know that you're at least driving the same amount of force or getting more force to that involved side. And then from there, it's just a super easy tool to keep on progressing that. As we get into running, we can look at jumps on there. As we get into change of direction, we can look at reactivity with different drop jumps. So we can keep on progressing or utilization of those force plates depending on where they're at from a functional standpoint within the rehab.
Yeah. Okay. I think that makes a lot of sense. That's great timing. And like you can use it all the way through. So your practice owners will be happy that you're getting good use out of it. It's not just return to sport testing. I love that. Talk to me about frontal plane, because we haven't mentioned it. Everything we have said is sagittal, right? But as these athletes get back on the field, we know that they're going to need to hit all their planes of motion. So when do you guys introduce frontal plane strengthening? That wasn't hard. That was not that hard of a question.
No, I was trying to give Rayce some more air. Philippine clogging the speed up. I think this injury predominantly is like a sagittal plane issue, right? Like majority of what we need to do is spend time developing like quad, and if it's a hammy graft that's involved, like it could be more like hamstring emphasis. So I think appropriately, like yes, majority of your drills are going to be in that like sagittal plane. But I would say like if I'm doing a session that's more like quad dominant in nature, like then I would say like 1 out of the 6 exercises are in that like frontal plane specifically, but with still a heavy emphasis on where the heavy emphasis on like applying load to the quad in that frontal plane. So like one that really sticks out in my mind that I utilize a ton is like just a lateral like shift, lunge, or squat, whatever you want to call it, with a slant board supporting the foot, and like with the cable column, so that the opposite hand is like cross body, and then you're just shifting all of that weight into that affected limb side. But like to Rayce's point on the constraint stuff earlier on, you get much more depth and like excursion in the exercise when someone like tips forward and they hinge. And so I think if your goal for that day is like quad but like some frontal plane involved in it, you have to be like probably the best you can do is some verbal and tactile cueing with this exercise, but like you have to be consistent with ensuring that they probably don't hit the same depth, but they're keeping that trunk more upright, so that you're making sure that like they're getting frontal plane quad, not frontal plane butt cheeks.
Yeah, that makes a lot of sense. Rayce, what about you? Frontal plane?
Yeah, I'd say I'm pretty similar there. If I had to say on average, probably between that 6 to 8 week mark, like as we've kind of progressed through our, acclimation to weight bearing with double leg tasks, as we progress more into single leg loading with split squats, eventually making our way into single leg squats or step downs. Right around that time point is when I'll start to introduce it. So if they can successfully go through, split squats for a couple sessions, mechanics look pretty solid, they have pretty good movement proficiency with it. At that point, it's like, okay, they can control sagittal plane pretty well with this. Then I start to look to introduce some sort of frontal plane variation. And it could be as easily as, let's say session 1, you introduce split squat. Things look really good. Session 2, you can still keep sagittal plane, but have more of what I'll call frontal plane bias and just have a weight in the contralateral hand. So now we're getting a little bit more force, from a frontal plane standpoint. Things go well there. It's like, okay, now we can maybe actually move in the frontal plane. Or if I want to go another intermediary step, maybe it's we're going to do a lateral slider squat. So I'm still primarily sagittal plane here, but as I descend, my leg or off leg is just going to go laterally there. Still more sagittal plane bias there, just adding a little bit more emphasis frontal plane. And then that last step could be we're actually going to go with more of a lateral squat where we have that wide stance. I'm actually going to have my center of mass and pelvis actually shift laterally and go back and forth that way.
Yeah, that makes a lot of sense. I just think it's important to keep that plane idea, the concept of planes and moving in different planes as we progress towards our strength. Too often it goes away, or too often it stops with hip abduction early on. So including that as part of the functional piece of rehab is really important. Okay, I think one last piece that I see a major weakness in our community is teaching cutting. So give me like a high level overview of how you approach this in your in-person course.
Yeah, we break this down, into these different categories of or principles. So planes is one of them. So you highlighted that, I think, and the same things would apply. Like, we want to we need to do a needs analysis like of the sports or basic cutting sports to realize like how much time we need to spend, in each plane. Again, like that sagittal plane is going to be the most difficult for the patient to, get back because of the effect of or how much quad loading is needed to do that. So we probably spend a little bit more like emphasis on acceleration, deceleration, like linearly over the course of the time. But the risk for injury and the mechanism for injury usually occurs in that like frontal plane or that combined motion plane. So it's important to address both. So we do it from a planar perspective, and then we also do it from what we call like a chaotic and non-chaotic environment perspective. So like non-chaotic environments would just be like ones that are pre-planned, right? Like the patient knows the drill. There's no reactive dimensions to any of the drills. And then, chaotic environments are those in which like there are multiple steps within the drill. There are reactive components to the drill. And then we break those further down into contact and non-contact related cutting drills. Okay. So there's like basically a tree. So you have like each plane broken down, within each plane, you have chaotic and non-chaotic drills. And then within each plane, within each category of chaotic and non-chaotic drills, you also have contact and non-contact related drills. And so that really guides your decision making on specifically like what are you planning on achieving within each session. Okay. So today might be linear or like sagittal acceleration and deceleration day. That's non-chaotic in nature, and there's no contact also involved. Okay, so that will tell you what 5 drills you want to plan for that day, and then another day might be something different. But that's really the framework that we work from in terms of like simplifying this process a bit of just like going out there and sticking 4 cones out and running people through like square drills because you don't know what else to do or what direction to go into. We find that this framework gives people a lot of idea about like, how do I break it down? And we give some examples, like 1 or 2 examples within each category. But, the list is endless. When you get further down the process of, ACL protocol, there are so many variables involved that it's harder to say, like, it's not going to be like squat, lunge, hinge, push, pull. Like there's just way more variations that are available. So we just use that framework to guide.
And Rayce, what would you say makes a good rep? Like what are the coaching points once you start venturing into this return to sport world?
So I think big thing, at least when we look at decel, is are they displaying, I would say what I'll call like relatively appropriate kinematics. So are we seeing like as they start to break, are we seeing their pelvis actually drop in center of mass lower? Are we seeing them starting to orient their trunk a little bit more posteriorly to handle those horizontal braking forces? I'd say those are the 2 big things. As we get into sharper angle cuts, especially when we look at like a 180-degree cut and we're looking at that penultimate step, we start to look at if their involved side is that penultimate step, what's that shin angle look like? What's our touchdown distance between our heel and center of mass? As we start to turn and pivot, what shin angle look like? What does trunk angle look like? As that opposite leg is turning and they're getting to that plant step, do they still have their momentum shifting towards that opposite side? So we have multiple things we can look at there. Ideally, I want that penultimate step taking up majority of the work. I just think when it comes to risk for contralateral tears, if we see them still having a ton of momentum and that plant step has to do a ton of decel and then also reaccelerate out of that cut, I'm just thinking that workload on that leg is just going to be drastically higher. So if we can
and if they're not, so that's great. I love those highlights as to what makes a good rep. If they're struggling with those, what do you do with that information?
Yeah, so I think a lot of times what we're in my experience, I feel like what we're seeing is probably a mismatch in what they can handle from a reactivity standpoint or RFD standpoint from the tasks that we're giving them versus the qualities that they actually have from their own capacity. And so from there, we probably need to scale back the intensity a little bit in terms of maybe their entry speed or entry velocity into that cut to at least kind of have a better match of where they're at from a functional standpoint to what we're trying to have them do from the actual task.
Yeah, that makes a lot of sense. It's a great answer. Okay, you guys have covered a ton here, so I appreciate the knowledge. I want to sign up for this course. First one is going to be held in Baltimore, so there's a link everywhere on our website to sign up. So make sure you sign up for it. I want to close with the Eric Cressy lightning round. Quick answers, Tim Stone, Rayce Hauser. You ready?
I'm terrible at this.
You're great at it. Okay. Number one, Rayce. Who not included in this call would rehab your ACL?
Jeremy Bayer or Bayer.
Oh, Bayer.
Bayer.
New clinical excellence coordinator at True Sports. So shout out to Jeb, as we call
Rayce
him.
2.0.
Rayce 2.0. Tim Stone, who's rehabbing your ACL?
Anybody that's unlucky enough to have me on their schedule.
I'm sure you're a pleasure. Come on, give me a name.
I'm really close to Woodbine, so I have to give Dr. Ann Lair my knee to work on for sure.
Okay.
It's got to be convenient. You got to have easy access to get in there. So,
dude, you know why that's a cop-out? Because when the physicians are like, we don't send them anywhere. We just ask them where they live. And that's such BS. But Ann Lair is great. Fine, I'll take that answer. Next, what is the future? PT. What is the future of ACL surgery and rehab?
Who's going for this one?
Both of you. So let's start with Rayce Hauser because I like your haircut.
Oh, fuck. I think they're going to continue to push potentially more non-op or cross bracing. It seems like I know there's one study that came out about it seemed like long-term return to sport rates were similar between surgical and non-surgical. So I think we'll see that route. Second answer is quad tendons will become less prevalent over time.
Because why? What are you seeing?
They stink.
Dude, they stink.
Why do they stink?
The timeline, when they give the protocol, I feel like a lot of patients are stuck on that timeline. Like, hey, protocol says I should be back between 9 to 12 months. In reality, it seems to be like a year and a half to 2 years out before I feel like they're probably in a good spot functionally to actually get back to sport.
Why is that? You think they struggle more with AMI stuff?
Yeah, I think because I just feel like the patellar tendon still part of the extensor mechanism. I feel like because we're actually taking more tissue, like direct tissue from more of the quad kind of itself, I think that's what's probably facilitating that longer AMI, longer restoration of strength. I forget the one article, but I think people were hitting like 70 or 80% LSI at 9 months for the quad tendon. And let's be honest, we're not waiting that long for our quad tendons to start return to run. So I think because of that, just because it takes so much longer, and I don't think just as a profession, we do a good job of highlighting like, hey, this is, functionally how long it takes. And I think people don't want to hear that. They're just so fixed on protocol I'm given from the hospital system says 9 months. Like I'm just focused on that number there.
Yeah. Yeah. Timmy.
I think from a surgical and rehab side of things, I think we can kind of pair these together. I think this is already happening. It's happened, it's come so far since we first started down in Baltimore. But I just think the understanding of each profession, like that gap has gotten a lot closer. Maybe that's because maybe we have a bit more of a presence and ability to communicate with surgeons. But when we first started treating ACLs in Baltimore, like you a long time before me, but when we were both
Okay.
both
Okay.
there, like
Okay. Take it easy.
long time. Like it's not that long ago that like we were having to like absolutely like fight for our patients' lives to get them to wait for 9 months. Like that just doesn't happen anymore. Like most surgeons are happy for that 9 to 12 month mark. Like it's very rare that they're not. I think they're also like much more invested in making sure their patients do seek some level of sports specific rehab or strength and conditioning before they get back on the field. So I think that's probably like beyond all tech like initiatives and like surgical techniques in terms of things that we can do to make it better, graft selection, all those things. I think a better understanding and like communication between both professions is really what I think is going to drive down that re-injury rate, right? So like patients aren't having to make decisions with two different opinions that are so far apart in their ear, right? Like if we can all agree that no one will tell someone to go back prior to 9 months, and also no PT will sort of like tell a surgeon what graft that they should do for this particular patient. I think that's like the goal. I think that's where we really make it steps forward in terms of like successful rehab with patients.
I also I think we take it for granted where we are. We're surrounded by so many hospitals. We have so many clinics. People, thank God, have like learned what true sports is. It's a place to go for ACL rehab. You're in the middle of North Dakota. Is that
Oregon?
No, I know, but where are you from?
Oh, yeah, I'm from South Dakota originally.
South Dakota. Okay, you're in the middle of South Dakota. Whatever. You're in the middle of nowhere. I think there's probably still gains to be made there. Another thing that we used to fight like hell on is how quickly we can see these patients. Even in Baltimore, which has surgeons coming out of our pockets, there are still surgeons that say, take 10 days before you go to rehab. We've come a really long way. Hopefully the future is day 1 post-op, day 0 post-op. We're seeing them. I think it really depends where we are. I just don't want to get too like pigeonholed to think that the whole world is where Baltimore or Oregon is with their rehab. Okay, next question. What is one thing that you've changed your mind on as it pertains to ACL rehab in the last 5 years? Tim.
I'm embarrassed to say this, probably mostly out of like a fear, but the amount of which that I utilize testing in ACL rehab. I think 5 years ago, like we didn't have access to force plates or Tyndek, and I wasn't happy with the output of like hop testing. And so basically like I threw the baby out with the bathwater. I was like, these are terrible. Like testing doesn't matter. You need to be a really good clinician. Just progress them 1% every day and you'll get them there, which is, not untrue, but like I like heavily rely on data now to help guide my ACL rehab. And I will say this is a plug to our staff in Glen Burnie too. Like I'm terrible in terms of like performing the testing protocols, right? Like getting it down and like the scientific method, I think that's involved in replicating and doing that. I think that's very important. We see a ton of college athletes that come back that have like 95% for their testing, and we send them through our protocols and they're like 75% or 80%. And so like I want my athlete tested by the same person with the same unit in the same parameters every single time. So I outsource to, shout out to Rachel Noble and Lucas Chang over in our Glen Burnie location. They do a fantastic job of testing athletes, but I just want to know I'm not screwing up the outcomes, like from driving to Woodbine and then going to Glen Burnie and doing it in Timonium. Like it's important, I think, to me that, we're testing them appropriately. So I'd say like that information has been gold for me in terms of directing the way I do my rehab.
Yeah. Rayce?
I got 2 things. First one is the importance of calf training and just hammering that early and often. Not only from a strength perspective.
Not anterior tib?
Not anterior tib. That's not going to fix all your knee pain or rehab your ACL. But the importance of the soleus in particular. So making sure we're getting testing measures on that in terms of not only a strength output, but also making sure we're getting on the force plates and doing various reactive tests as well, just to make sure that we're covering sort of all of our physiological bases for not only the quad and the knee, but also looking at the foot and the ankle as well. Second is understanding, like, when we go through our testing, like the test tests what the test tests, and it's just that is very task specific. And so if I have them do a double leg counter movement jump, I see certain metrics from impulse asymmetries or how much they're using left versus right, how high they can jump. Like, that is specific to that task itself. And we're then making assumptions and generalizations from that task as to how well they're going to be able to use their knee in other tasks that are similar. So I think just understanding that those tests are very specific. Everything we do, in a sense, is very task specific, but just understanding that when we do test, we're then making assumptions and jumps from a logical reasoning standpoint to other tasks and other exercises within their rehab.
Yeah, I think that makes a lot of sense. We haven't mentioned LET and ALLs. Do you guys see that being a piece of the future, or is it just the fancy new toy?
I think it's probably here, to stay. I think it had that like really initial like major like influx, and I think especially around here. I think that's probably here to stay in some capacity until something replaces it. I think there's probably more going to come out in terms of some of the complications that occur with that, right? The difficulty sometimes in regaining range of motion and how that affects the overall outcome of surgery, right? Because it's all great to have this beautifully like, potentially stronger knee in rotation. But, if there's a ton more re-tears, not because of the choice of selection, but because they don't get range of motion early on, so they don't get strength, so they don't like develop. Like, I think that is a risk, with that surgery. So I think it's here to stay. It definitely doesn't do well in a scenario where like the athlete doesn't have great rehab, right? Like, you're just not gonna, sometimes you get those patients that don't need a lot of range of motion help, and they just like, they went to shitty PT and it still looks great, and they did nothing, and they're just like lucky. They're just like hypermobile or whatever it is like that. I think when you add that LET, or when you add any other surgery, increase the volume of surgery, meniscus, LET, like all that kind of stuff, you just increase the risk of range of motion issues, which downstream has a major effect. So maybe if we can improve or decrease the issues with like knee stiffness and still maintain that, and also to like, if you're taking tissue away from something, you're removing something that right, that's like there for a reason. But it's certainly, I think, probably still like the best option that we have right now, right? BTB, LET, and a meniscal repair. Like, if they have a meniscus injury, like, that's I think the best option currently.
Yeah, I think, and we've seen it here. We've seen surgeons get better at it and complications go down. I think the future is when they get really good at LET, being an LET hamstring as the new gold standard. I think they've gotten so much better at harvesting hamstrings. I'm not seeing the re-tears that I used to see. I'm definitely not seeing the patellar tendonitis that is almost inevitable. And if you can bolster that knee with the LET, I could see that being the future. Not that you guys asked me, but I think that makes a lot of sense. Like, the evolution I was talking about, like, we've seen docs suck at using LET and have all these complications, and then other docs become really good at it, and we don't see those complications. We also know that re-tear rates are lower with it. So if we can avoid those complications that Dr. Stone highlighted, I could definitely see that being the future. Last but not least, the biggest mistake PTs make in ACL rehab. But you only got 6 seconds because we got a limited attention span here, Tim.
Range of motion.
What did you say, Rayce?
Oh, sorry. I was asking if Tim was going first.
Yeah, but you only have 6 seconds. Go, Tim.
Okay, so I think it's, I said early and often, and then getting the range of motion symmetrical, within the first week or two.
Good answer. Rayce?
not loading heavy enough, or
I knew you were
having
going to
great
say that,
exercise.
Rayce.
Yeah, not great
No.
parameters for like that sort of mid-stage phase where we're starting to really try to improve quad strength. That's just a bunch of still weighted or ankle weights for straight leg raises as our main quad exercise, or it's just a bunch of double leg squats that are just RDLs. So just more aggressive with quad loading and good exercise setup to allow to drive good quad loading.
That's what I like to call constraints.
Can I argue that before we finish?
Yeah, go, Tom.
Here's my argument against that. You have infinite amount of time in someone's like life to regain strength, but if you don't regain range of motion early on, you're SOL. So like, yeah, I totally agree with you, Rayce. Like, especially if you're an athlete that's like a seasonal athlete, right? You only have a time period to get back. That's very, very true. But like, to me, like if, they are still at 70%, as long as they don't just make a bad decision on timing, if they're 70% at 15 months out, they still have the opportunity to regain the last like 30%.
Yeah.
Whereas like, if you're missing 10 degrees of extension, you're cooked. You're never going to get it back. So there's my debate.
Okay, good rebuttal, but Rayce couldn't be like, duh, I agree with Tim. Like he had to say something else. So should have started with Rayce. Okay, gentlemen.
So we'll start talking like the quad LSI, like 5 years post-op, like not being symmetrical and all that. So no, I definitely agree with Tim though. Like, not getting range of motion back, like definitely important. And the amount of people I've seen 4 weeks, 8 weeks, 12 weeks, you name it, post-op, not have range of motion back. And then we sort of have, I'm going to cuss here, but the shit show or the storm of now we're looking at MUAs, lysis, various procedures to get range of motion back. And like Tim said, it just freaking pushes the timeline down much further.
Takes forever. Good points. Gentlemen, tell everyone listening where they can find you. Tim.
You can probably find me, I guess, limited these days, a little bit less on Instagram, dr.stone.dpt. Or you can email me at tim@truesportspt.com. Or
you could see him in Woodbine because he lives right there. Rayce, how do we find you?
On Instagram, Rayce, I think it's Rayce_Roke, so ROKKE as the Instagram handle.
Okay, and guys, I implore you to learn from the best. Come to Baltimore, learn in person how to take an ACL all the way from post-op day one, if not from even before prehab, all the way back to the field. It's the only course like it. You guys heard here exactly why this is a special and unique learning opportunity. Make sure you sign up for the upcoming course. You can find that on our Instagram handle, True Sports PT. You can find it on our website, truesportsphysicaltherapy.com. Check us out, guys. Thank you so much for listening. Bye-bye. Bye-bye.